Hi, my name's April. I'll be talking about disc golf and cerebral palsy. So, the objectives for this video are to discuss a brief overview of disc golf and cerebral palsy, and then go over my SOAP plan from an occupational therapist standpoint. So what is disc golf? Disc golf is similar to regular golf. However, instead of using golf clubs and balls aiming for a hole, disc golf players use golf discs and aim for a disc golf basket, which is a pole extending up the ground with chains and a basket where the disc lands. The object of the game is to complete each hole in the fewest number of throws, starting from a tree area and finishing at the disc golf basket. Generally, a course is 9 or 18 targets long. Players start from a hole or at hole 1 and continue until they complete the course in order, playing through to the last hole. The player with the lowest cumulative score wins. So what is cerebral palsy? Cerebral palsy, also known as CP, is a group of disorders that affect a person's ability to move and maintain balance and posture. CP is the most common motor disability in childhood. Cerebral means having to do with the brain. Palsy means weakness or problems with using the muscles. CP is caused by abnormal brain development or damage to the developing brain that affects a person's ability to control his or her muscles. The symptoms of CP vary from person to person. A person with severe CP might need to use special equipment to be able to walk, or might not be able to walk at all, and might need lifelong care. A person with mild CP, on the other hand, might walk a little awkwardly, but might not need any special help. CP does not get worse over time, though the exact symptoms can change over a person's lifetime. All people with CP have problems with movement and posture. Many have related conditions such as intellectual disabilities, seizures, problems with vision, hearing, or speech, or changes in the spine such as scoliosis, or joint problems such as contractures. Doctors classify CP accordingly to the main type of movement disorder involved. Depending on which area of the brain is affected, one or more of the following movement disorders can occur. There's spasticity, which is stiff muscles, and it's the most common type of CP. Spastic CP affects about 80% of people with CP. People with spastic CP have increased muscle tone. This means their muscles are stiff, and as a result, their movements can be awkward. Another is dyskinesia, which is uncontrollable movements. People with dyskinetic CP have problems controlling the movements of their hands, arms, feet, and legs, making it difficult to walk and sit. The movements are uncontrollable and can be slow and writhing or rapid and jerky. The third type is ataxia, which is poor balance and coordination. People with ataxic CP have problems with balance and coordination. They might be unsteady when they walk. They might have a hard time with quick movements or movements that need a lot of control, like riding. They might have a hard time controlling their hands or arms when they reach for something. There is also something called mixed CP. Some people have symptoms of more than one type of CP. The most common type of mixed CP is spastic and dyskinetic CP. So, there are different ways to play disc golf in an adapted setting. The first thing that comes to mind in thinking of adapted disc golf is making the distance one has to throw shorter. The second is to make the hole larger, and I'll discuss more about adapted disc golf more in depth within my SOAP plan. So with my SOAP plan for this objective area, I'll be working with a 9-year-old girl named Jane. We will have 45 minutes for our lesson. Jane has spasticity, cerebral palsy. Only her right side is affected, making her hemiplegic. Due to her stiff muscles, she has difficulty walking and may need assistance. For the objective setting, Jane's right side is affected, causing her right arm to be bent, hand floppy, and walk on her tiptoes. Her entire right side is weakened, however, her left side is relatively normal. So again, as said in the subjective section, Jane has spasticity, hemiplegic cerebral palsy. So, we will begin in a normal clinical setting to focus on gross motor movement, specifically on the right side of the body. We will use little physical support as possible. We will work on walking, shoulder mobility, grip strength, and elbow mobility. So for the exercises for the walking gait include ankle dorsiflexion in a passive way. So from a seated position, the patient will cross the affected leg over to the other leg. She will move her right foot into dorsiflexion using her left hand to move the foot towards her knee. Then she will move her foot into plantar flexion by extending her foot backward. She will repeat this 10 times. If the exercise is too easy, she will do the exercise actively instead of passively. The second exercise we will do is the assisted toe raises passively. This exercise may be a little difficult to get into the starting position. She will place the left foot under the right foot whilst in the seating position. Then she will use her left foot to assist her right foot up while keeping the heel on the ground, then release back down. Then she will repeat this 10 times, and if it's too easy, then she will perform it actively rather than passively. The third exercise is heel raises actively. She will remain seated to perform heel raises. She will start with the feet flat on the ground, then point toes and lift the heels off the ground and repeat 10 times. Then we'll move on to the leg exercises for the gait training. And with that, the first exercise with this will be the seated marching. So from a seated position, she will lift the right leg up into the chest and then place it back down onto the floor and keep her back straight and maintain controlled movement. She'll repeat with the other leg, alternating back and forth 10 times, and there will be physical assistance as needed. Then with the second, for the leg exercise will be the knee extension. So from a seated position, she will extend her right leg out in front and parallel to the floor and avoid locking the knee. Slowly bring the foot back down to the floor, alternating back and forth between right and left legs, and repeat 10 times for each leg. Then another exercise is going to be walking along a line. So for this exercise, there will be an open area with a piece of tape 10 feet long on the floor. The patient will be asked to stand on the tape and walk along the tape, trying not to get more than 6 inches away from the tape. She will repeat this 4 times. Then we can go on to the shoulder exercises. So the first of the shoulder exercises would be the weight-bearing lean. So from a seated position, the patient will prop herself up on her affected arm, which would be her right arm, about 1 foot away from her body and lean into it. If the stretch feels comfortable, she will continue for 10 seconds. If it is uncomfortable, she will stop immediately. So if it's comfortable, then she'll do it for 10 seconds. And after the 10 seconds, she'll place the other arm on the other side so there is support from both arms, and she'll rock from side to side, shifting weight from one arm to the next. The next exercise is the tabletop pushing movement, where she will place a water bottle on the table and push it across the table using the back of her affected wrist, which would be the right wrist, keeping her arm relatively straight. And I'll ask her to try her best to avoid hiking up her shoulder. And then once the bottle has reached the other side of the table, she will hook the front of her wrist around the bottle and push it back, and she will repeat this 5 times. The next exercise is the tabletop punching movement, where she will place the bottle in front of her, and she will have to push it away with the affected hand in a fist, hence the punching movement. And she'll keep the forearm on the table and try to resist hiking the shoulder, and she'll repeat this 5 times. Then we'll go on to the hand and wrist exercises. So the first exercise for this will be the wrist bend movement. Keeping the elbow on the table, she will use her left hand to stretch her right wrist, or to stretch her right hand at the wrist, and stretch it backward and forward slowly 5 times each. And then another exercise we could do would be the wrist side movement. So she'll place her right hand on the table with the palm down, use the left hand to slide the hand to the left and then to the right, and she will focus on initiating the movement solely from the wrist, and she'll repeat this slowly 10 times. Then we can do the wrist curl, which is similar to the bicep curl, except it's with the wrist, and she will grasp a water bottle in her affected hand and use her non-affected hand to prop and support the arm, and then she'll allow her wrist to stretch down and then curl the wrist up, and she will repeat this 10 times. Then we can do the rolling movement. So she'll place the water bottle in the affected hand and curl the fingers in to grasp the water bottle and then release the grip, and she'll repeat that 10 times. And then, so for the final warm-up, we will do a pen spin. This exercise can be difficult. So she will place a pen on the table and use the affected fingers to spin it, and she'll try not to move her shoulder during this, and she will attempt to spin the pen 15 times. So after the warm-up, we'll go outside to play disc golf. So the materials needed for this are 9 hula hoops with stands to be used as frisbee catchers, and then we'll need frisbees and cones with the numbers to start, or to number the tees, and then smaller cones as spots to throw from. So I'll need to set the hoops outside free of walking traffic and other obstacles. There will be 9 hula hoops on stands set up. The hoops will be 15 to 20 feet apart. There will be a set starting point for the first hula hoop, then the patient will throw from the one hoop to the next. Each hoop will be numbered with a cone. I'll demonstrate the goal of the game, or that the goal of the game is to throw the frisbee through the hoop. So for actually playing the game, the patient will pick out whichever frisbee she would like. The patient will begin at the start, and will attempt to throw the frisbee at the first hula hoop. Then she will walk over to wherever the frisbee landed and attempt to throw the frisbee again until she gets in the hoop. The game will continue until the patient made the frisbee in all 9 hoops. The occupational therapist or occupational therapist assistant will be playing with her to make the game more fun, and then the patient will have as much physical assistance as needed, but the occupational therapist will be expecting minimal help. So after completing the game, we'll go back inside, and then I'll ask the patient her opinion on the day, and her response will determine if the activity is continued or discarded for the future appointments. And that is my lesson for disc golf with someone with cerebral palsy.